Okay, let's dive right into these high-yield, exam-facing clinical algorithms for ophthalmology. To master ocular pathology, we really have to establish that immediate clinical divergence. It all comes down to lesion location, chronicity, and the initial presentation. Things like eyelid inflammation, anterior chamber pain, or acute vision loss.
So our clinical presentations basically split into three main buckets: eyelid lesions, the painful photophobic eye, and acute vision loss. Let's go ahead and break down the eyelid first.
First up, blepharitis. This is characterized by chronic or sometimes recurrent inflammation of the eyelid margins. We're looking for distinct scaling and crusting right at the base of the eyelashes. It presents with redness, irritation, and swelling. Imagine a patient coming in complaining of waking up for months with irritated, swollen eyelids covered in this dry crust. A bunch of things contribute to this: seborrheic dermatitis, rosacea, allergies, bacterial or viral infections, and even Demodex mite infestations. Treatment requires long-term lid hygiene and warm compresses. Now, this is absolutely crucial. You have to explain the recurrent nature of this to the patient so they actually keep up with this care even after they start feeling better.
Now let's contrast a painless chalazion with a tender hordeolum, which you probably know as a stye. A chalazion is a granulomatous inflammation caused by an obstructed meibomian gland. It shows up as a chronic, solitary, rubbery, and totally painless eyelid nodule, usually on the upper eyelid. A hordeolum, on the other hand, is an acute, focal infection. It's often caused by Staph aureus, and it can happen in a Zeiss gland externally or a meibomian gland internally. This one causes an acute, tender, erythematous nodule or pustule right at the lid margin or inner lid. For both of these, your initial management is going to be warm compresses. It's only if you have a persistent hordeolum lasting 1 to 2 weeks or a really large chalazion that you step up to incision and curettage or drainage.
Moving to the medial canthus, we have dacryocystitis and congenital dacryostenosis. They present in the same area but require completely different management. Dacryocystitis is an acute infection of the nasolacrimal sac. The presentation is painful erythematous swelling over the medial canthal region, often with purulent discharge from the punctum if you apply a bit of pressure. Your next best step here: systemic antibiotic therapy and drainage when needed. Congenital dacryostenosis, though, is just an incomplete canalization of the distal nasolacrimal duct. An infant will come in with increased tearing and eyelash crusting, but, and this is a big point to remember, they will have clear conjunctivae and absolutely no acute pain or purulent swelling. Because that congenital dacryostenosis is just an incomplete canalization, the definitive initial step is simple observation combined with lacrimal sac massages to help force that duct open. Surgical probing of the duct is strictly reserved for when symptoms persist beyond 6 months of age. So observe initially, use massage, and only probe if it's persisting past that 6-month mark to avoid unnecessary procedures. Shifting gears to the painful photophobic eye, let's talk about anterior uveitis. This presents with a classic ciliary flush, that's prominent scleral hyperemia right at the corneal margin. You might also notice a hypopyon, which is the actual layering of inflammatory white blood cells right in the anterior chamber. The patient is going to come in with acute ocular pain, severe photophobia, decreased visual acuity, and your exam will show a constricted pupil. Urgent management is key here. You need dilating eye drops like cyclopentolate to relieve that pupillary spasm, along with topical glucocorticoids, and you definitely want to get ophthalmology involved. Nailing down the etiology of anterior uveitis requires a slit lamp examination and targeted testing based on systemic clues, because the causes include a variety of autoimmune and infectious processes. If there's a history of lower back pain, you should immediately suspect spondyloarthritis, reactive arthritis, or ankylosing spondylitis. You've got to check for HLA-B27 and grab a pelvis or spine x-ray. If respiratory symptoms are in the mix, think sarcoidosis and order a chest x-ray. Other really vital associations include inflammatory bowel disease, plus infections like herpes viruses, toxoplasmosis, HIV, and syphilis. So targeted serology is very often the right move.
Now let's jump into acute, painless vision loss. This requires really precise differentiation on the fundus exam. A pale retina with a cherry red spot? That's central retinal artery occlusion. What about extensive retinal hemorrhages and optic disc edema? That points straight to central retinal vein occlusion. If a patient, especially someone with advanced diabetes, reports floaters, photopsia, or flashing lights, and a progressive visual field defect, you are looking for an elevated retina, which indicates a retinal detachment. These are often tractional in diabetic patients. And if the fundus is obscured with floating debris and an absent red reflex, that indicates a vitreous hemorrhage, which is another really severe complication of proliferative diabetic retinopathy.
Let's drill down on central retinal artery occlusion for a second. Severe retinal ischemia causes whitening that sharply contrasts with a cherry red macula right in the center. The macula stays red because it's actually getting collateral blood supply from the choroid. This is a real emergency. The immediate management steps involve ocular massage and reducing intraocular pressure through anterior chamber paracentesis to physically dislodge that embolus.
We also have to watch out for medication toxicity. Suspect this if a patient on long-term therapy complains of experiencing months of black spots or a central visual change alongside bullseye macular lesions. This classic presentation points directly to chloroquine or hydroxychloroquine toxicity. To prevent irreversible damage, patients on these medications absolutely require a baseline ophthalmologic evaluation followed up by strict annual monitoring.
Finally, let's lock in some crucial medication and systemic traps. Cataracts present with gradual, painless vision loss, glare, halos, a decreased red reflex, and lens opacity. These actually tend to pop up earlier in patients with diabetes or HIV, and surgery is indicated once visual impairment starts affecting daily function. Then there's open-angle glaucoma, characterized by painless peripheral vision loss and elevated intraocular pressure. Medical management involves topical beta blockers like timolol. But here's the trap. Giving a non-selective beta blocker to a patient with severe asthma, COPD, or bradycardia can really worsen their systemic condition. Lastly, never forget that diabetes can cause transient refractive changes just from hyperglycemia, on top of all the serious risks we've discussed, like cataracts, glaucoma, macular edema, vitreous hemorrhage, tractional retinal detachment, and proliferative diabetic retinopathy. All of these require active, dedicated ophthalmology care.